Hello, I'm Jeffrey Popma, Vice President, Chief Medical Officer at Medtronic for Coronary Renovation and Structural Heart. And I'm delighted to be with Dr. Shirai today, who's the Director of Cardiology at Kokura Memorial Hospital. Dr. Shirai, welcome for today's interview.
Yeah. Hi, Jeff. Thank you very much.
Good. Our purpose today is to be a little provocative, a little thoughtful, and provide some current insights into the use of the self-expanding supra-annular Evolut platform. You know, we've gone through a lot of data collection with our Japanese colleagues and our US investigators in the United States at high-risk patients for surgery, at intermediate risk patients for surgery, and now in low-risk patients for surgery. And our FDA has now approved the use of Evolut Pro Plus technology for patients who are low risk for surgery. It's made a big difference. Things have changed in Japan as well. Tell me how things have changed for low risk patients in Japan.
So at first, the TAVR was introduced to 2017, and at first, only high risk is the candidate for TAVR. But for a long time, and 7 or 8 years, only the high risk is the candidate for TAVR. But after the presentation of the low risk trials, so this August in Japan, at last the low risk. All of the risk was the indication for TAVR. So high risk, intermediate, and low risk. And the new Japanese guideline published 2020, there is no classification of the surgical risk. So all of the patients were equally indicated for such as SAVR and TAVR for the patient for treating for aortic stenosis patient. At first, clearly not cut the indication for TAVR and SAVR at age, but around 80 and out more than 80, the TAVR is the first. TAVR is the first indication, and the less than 75, SAVR is the first to choose. But the 75 to 80, and we have to consider the anatomical suitability, and the patient preference, and more the patient preference and the background of the patient, such as the
Yes.
high comorbidity or not. So now recently, our team didn't discuss about the patient selection according to the surgical risk.
Exactly.
Yeah.
And I think that's the real advantage. In the US, our age cutoff is a little bit lower. Well, let's talk about a very important factor about why we would choose a supra-annular valve.
Yeah.
From the very beginning of Evolut, core valve and now Evolut, we know that the gradients are lower with a supra-annular valve than an annular valve. And we now find in some of our studies in the US that it's even more pronounced in patients with small annuli. You've done a lot of work with patients with small annuli. Can you talk with us about your impressions of gradients after supra-annular and annular valves in your patients in Japan?
Thank you very much. So it is very important question. So as you know, the Japanese patient is very, very small and tiny ladies, and so most of the more than half of the patient is a smaller size valve, just as the 26 and 23 millimeters. 23 millimeters in balloon expandable and the 26 millimeters self-expandable. So more smaller patient, we usually choose the supra-annular valves because the excellent hemodynamic status after implantation, and what is the most important is a little bit small percentage of the valve thrombosis and
Yes.
hemodynamically problematic valve thrombosis is lower in supra-annular valves. So very large annulus and the large valves, a little valve thrombosis is not so the problematic, but the very, very small patient and the very small annulus, the valve thrombosis also the extremely lower the effective orifice areas. So we prefer to choose self-expandable valves for the very small annulus patient.
Now, one of the things that we're learning in the US is the relationship between the gradient at the end of the procedure and long-term valve durability. And we had an important abstract that was presented at the ACC by Dr. O'Hara, and he showed that the residual gradient was a very important predictor of later hemodynamic valve deterioration. So for your patients, particularly those that are 75 and older, we would like to have one valve for the patient, right? And the one valve is going to be the one that's the most durable. Does that come into your, do you think about that when selecting? Do you think about durability when you're selecting valves for your patients?
Yes, thank you very much. So it is very important because as you said, the O'Hara's data shows a very excellent durability, very excellent hemodynamics. It allows to the good valve durabilities. So our aim for the patient with for treating the aortic stenosis patient is a long life management, only one valve. So the durability is should be focused on the selecting for the treating selecting the valve. So maybe the good hemodynamic status after implantation is a first key for the long durability. And in our outpatient department, we check annually the patient after implantation. We also surprised that is a great result, single digit mean pressure gradient, and very, very nice hemodynamic status. So the first cohort was implanted since 2016. The 5 years passed, but the we don't know. I don't have any experience of the valve SVD in self-expanding valve patient.
Well, we are going to follow all of our patients. We're going to follow all of our patients for 10 years, both for our TAVI trials and our low-risk patients. And I want to discuss briefly several important factors about lifetime management. One is getting pacemaker rates down. 2, working on commissure alignment so that we can actually have access to the coronaries. And 3, think about how we would manage patients who did come back with a core valve or evolute failure in terms of our valve and valve solutions. Can you address a couple of those comments? Pacemakers, commissure alignment, coronary access, and TAV and TAV. What do you think? What's important to you?
Yeah. what is most important is TAV and TAV because the patient, so in US guidelines, 65 years of the patient is a candidate for the TAVR, but most of the patient years 65 should be implanted two valves, but the TAV and TAV is important, and the coronary access after implantation of second valve. But the most important is durability of the first valves. So yeah. And the before thinking about the durability, we have to think also the acute phase patient mortality, such as the conduction disturbances is a risk for the long-term mortality, and also the commissure alignment causes the coronary obstructions. That first, we should think in implantation that first the conduction disturbances and the commissure alignment, and then we should think the long-term result. So maybe the TAV and TAV. As the TAV and TAV, I also hope the device for the coronary access device, such as the Basilica. So yeah, Basilica, easily Basilica device. I hope in order to implant the second valve.
Those are excellent, excellent comments. We have worked very hard with our cusp overlap technique to provide a good implantation so that we can reduce our pacemaker rates. We've now worked for putting our flush port at 3 o'clock to have good commissure alignment, so we'll have good coronary access. And we are indeed working on a number of solutions for TAV and TAV in the future to be able to make sure that we can plant another valve, a balloon expandable valve inside the self-expanding valve to preserve coronary access, as well as coming up with leaflet modification techniques in the future. Let me just close and have you make some final comments about where you think Evolut should go in the future. What should we do in the future?
According to the introduction of the low-risk patient, the proportion of the bicuspid valve patient is increasing. So in order to treat such a very young patient, we have to fight against the bicuspid valve. So, but the recently not so long-term durability and the long-term result is not obtained about the bicuspid valve treatment, bicuspid valve treatment. So I hope that the bicuspid valve treatment result, I wish it is very excellent one.
Yeah, and we will work with you on that. You have many more bicuspid patients in Asia Pacific than we do in the US. So we'll work with you. Dr. Shirai, thank you so much for this interview today. It was excellent.
Thank you very much.
I learned so much about how you treat Japanese patients. Yeah. And it's very, very important that we continue to work together worldwide so that we can actually come up with better therapies for our patients. Thank you so much.
Thank you very much.